Please somebody respond. Good
Yes,
morning.
sir.
So are you ready? Okay, so we'll start our class. Okay. So if you have any comments, if I am not audible or if you can't understand anything, if you want me to pause, you can just text me. Okay, so that will be good. So today's topic is acute intestinal obstruction. Okay, please continue commenting. Okay, so that I can understand you are with me. Okay. So the topic acute intestinal obstruction, it is as you know, it is very common surgical emergency condition. As a surgeon or in your stage after you become a graduate, when you are doing your duties in the emergency, it is one of the common surgical problem you will encounter in your clinical practice. Okay. So before we go to the definite management of acute obstruction, we'll first discuss the common concept about acute obstruction. Okay, so uh, when we talk of acute obstruction, there are two concepts about obstruction which you need to understand. When we talk of the etiology of obstruction, the causes are classified as dynamic and adynamic. Okay, so dynamic means in the intestinal lumen there is some mechanical obstruction. Okay, the peristalsis is intact and it is working against the mechanical obstruction. While adynamic obstruction, the peristalsis is absent or inadequate or is in non-propulsive form, but there is no actual mechanical obstruction. Okay, so in real sense, adynamic obstruction is not a real obstruction, it is a virtual thing, but the patient they will present in similar way as a patient with dynamic obstruction. Okay, so they are classified into two categories of intestinal obstruction. Okay, so if you talk of dynamic obstruction, we can see that the classification of the causes is like this: intraluminal causes, intramural causes, and extramural causes. Okay, intraluminal, and you need to understand that all these causes they are mechanical. Okay, somehow from inside or from outside they will cause the obstruction of the passage of the content in the intestinal lumen. Okay, so inside the lumen, it could be impacted feces, it could be foreign bodies, gallstones, bezoars. Bezoars, you know, these are the obstructive objects which are ingested by the patient and they gradually enlarge because of the addition of the undigested particles, like it could be hairs, it could be undigested plant products. Okay, and these form big mechanical bodies which cause obstruction. Though they are rare, we can encounter those conditions as well. Okay, so intramural means within the wall. Okay, so it could be tumors, it could be inflammation. Okay, and the extramural causes like adhesions or these are more common. Okay, and volvulus causes percentage wise, you can see in this chart that most of the intestinal obstruction they are because of adhesions and bands. Okay, and these results secondary to abdominal operations. Okay, so it could be operation for benign conditions or malignant conditions for emergency conditions. Okay, so later on over the wound the patient develop obstruction. Okay, because of the adhesions, this is most common. Okay, in some patients the adhesion may develop without any surgery, prior history of surgery. In some patients, there may be history of some inflammation, there may be history of tuberculosis or some unknown or subclinical infections. Okay, so whatever the mechanism, the adhesion, they come as the first cause for intestinal obstruction. It is followed by tumors and inflammatory conditions in equal percentage, followed by other less common conditions like obstructive hernia, intraluminal causes, and miscellaneous. Okay. So, students, are you with me? Following?
Yes, sir.
Yes, sir.
Okay, good, good. So I'll continue. Okay. Uh, Then coming to dynamic obstruction. Okay, so this is a condition which may result due to various metabolic and physiological derangement in the bodies as well as vascular causes. Okay, so paralytic ileus is the most common cause for dynamic obstruction. Paralytic ileus, by the term itself, you can understand that the bowel goes to paralysis because of the post-operative handling. During intraoperative bowel handling, the bowel goes to ileus and it does not recover for prolonged period. May be related to some infections, may be related to spine fractures due to neurological cause. Okay, it may be due to irritation by blood in the peritoneal cavity like hemiperitoneum or sometimes retroperitoneal hemorrhage. And the most common cause in our scenario, in our clinical setting, is hypokalemia. Okay, sometimes hypocalcemia and hypomagnesemia may also cause paralytic ileus, but hypocalcemia, this is the most common electrolyte imbalance. Okay, then when there is thrombosis of the vessels which are supplying the intestines, okay, that may result in dynamic obstruction. And sometimes there is pseudo obstruction in metabolic conditions like severe jaundice, uremia, okay, then septicemia, some drugs, and connective tissue disorders. In that condition, there is no obstruction, nothing in the bowel, but the bowel does not function, and the patient is not able to pass stool. Patient will have to abdominal distension and vomiting, but there is no actual obstruction. Okay, so these are the metabolic and other physiological conditions which may result in dynamic obstruction. Okay, but they are not so, though they are included within the surgical management is always medical. Remember. Okay, now another important concept you need to understand when we are talking of intestinal obstruction is to identify the level of obstruction. Okay, as you remember the anatomy of GI tract, it is around 5 to 6 meter long tract. Okay, there are different parts like small bowel, large bowel, that also divided into different parts. Okay, we have to understand at what level the obstruction is occurring. Okay, and based on that, our management, surgical management, will vary. Okay, so by some clinical symptoms and sign, we may be able to distinguish whether the obstruction is at the level of small bowel or large bowel. Okay, in small bowel also, if it is at the level of jejunum, we say high small bowel obstruction, and if it is at the level of the ileum, then we say low small bowel obstruction. Okay, so proximal or distal small bowel obstruction. Okay, so remember, when there is high obstruction, okay, in the jejunal region, then only profuse vomiting, this is the most common and prominent symptom, followed by dehydration. Okay, abdominal distension and constipation, these are less common, okay, compared to profuse vomiting. Okay, while in the low small bowel obstruction, pain is prominent symptom followed by central distension. Okay, there is vomiting, but it is a bit delayed compared to high obstruction. Okay, in contrast, large bowel obstruction usually present with early pronounced distension and mild pain. Okay, vomiting and dehydration are lateral. Okay, so the causes usually in large bowel obstruction, the causes are carcinoma. Okay. Then type of obstruction. Clinically, it is important to know whether it is simple obstruction, strangulated, or closed loop, because the management, the urgency of the management depends on type of obstruction. If it is simple obstruction, then sometimes you may try different conservative or non-operative intervention procedures. Okay, if it is strangulation or impending strangulation, then you may have to immediately take the patient to theater without losing any time. Minutes, 1 minutes are important. Okay, in such case. Okay, then closed loop obstruction. So what is this? Simple obstruction? There is mechanical obstruction, but there is no vascular compromise, which means that the viability of ball is not at risk. Okay, so you can wait for some time and you can manage non-operatively. You can take some time. Okay, you can take some time for evaluation and management. Strangulation means there is significant impairment of blood supply, usually associated with external compression by hernias or valvular intersuspension, whatever. Sometimes because of mesenteric. In fact, even bands and adhesions also sometimes cause vascular compromise. Okay, in that situation, you cannot wait. You have to immediately take the patient to theater. Okay, then there is a condition called closed loop obstruction. I'll show in picture in later slides. Okay, the ball is obstructed at both proximal and distal end. Okay, so only that part of the ball is compromised. Okay, so if you see these two pictures, okay, the first picture, ball loop is entering through the arnial orifice, and the proximal and distal ball loops. Okay, they are compressed. So only this part of the ball is obstructed. Okay, so proximal and distal part are intact. Similarly, if there is obstruction at the level of ascending colon or hepatic flexor, what will happen? There is physiological narrowing at ileocecal junction, and there is pathological narrowing at the hepatic flexor. So this part will have closed loop obstruction. So the features of obstruction and the pathophysiological changes that will occur only in this segment. Okay, in this kind of obstructions, the patients will have less prominent symptom. Pain will be localized in certain quadrants or certain part of the abdomen. The vomiting and the distance are not so pronounced. So these conditions are usually difficult to diagnose in earlier stage. Okay, that's why they are clinically important. Then what happens? Why acute intestinal obstruction is that important? What are the consequences of obstruction? Okay, so let's see in these slides. It's proximal to the obstruction because the fluid and the gas they cannot pass distally. There is accumulation of excessive amount of fluid and gas, okay, which results in abdominal distance. Then gradually there is increase in the intra-abdominal pressure and there is reflex vomiting. Okay, so the patient will lose lot of amount of fluid through vomiting and the patient will develop dehydration. Okay, then because of the constant obstruction, the proximal part of the ball will be dilated and there will be reflex contraction of the smooth muscle. So this will lead to a sequence of contraction and dilatation. Okay, which will lead to severe colicky pain. Okay, so that is the pathophysiology behind colicky pain in intestinal obstruction. Okay, then to overcome the mechanical obstruction, there may be sometimes increased peristaltic movement of the bowel. Okay, so that is another consequence. Okay, so if the bowel obstruction is not overcome, if the increased peristalsis that cannot propel the mechanical obstruction, then ball goes to atony. Okay, then there will be continuous dilatation, but there will be no reflex contraction. Okay, the absorption capacity will be decreased. The ball will become flaccid. Okay, and this is associated with some vascular damage. Okay, and ultimately there is next step. There is next sequelae, which is strangulation. Okay. So distal to obstruction, what will happen? Actually, nothing will happen in the distal to the obstruction. Nothing will pass and bowel will collapse. Okay. So the bowel which is distal to the obstruction that will remain healthy. Okay. It's very interesting. Okay. The proximal part of the bowel is distended by two factors, as I already told, gas and fluid. So where does this gas and fluid come? Okay, so the gas mainly comes from three sources: from the swallowed air, from diffusion from the blood into the lumen, and product of digestion and bacterial activity. Okay, mainly the gas is formed of nitrogen and hydrogen sulfide. Okay. Now the fluid is mainly formed of what the patient had already ingested, then the digestive secretions, as well as the fluid which leaks from the blood into the lumen of the intestine. Okay, and there is dehydration. This is the very important physiological consequence of obstruction. Okay, dehydration, which leads to further electrolyte and metabolic imbalance, and the life-threatening consequences of bowel obstruction are somehow related to severe dehydration. Okay, so this occurs because of the decrease intake. As you understand, you can understand, the oral intake is decreased. Okay, the intestinal absorption is decreased, then there is excessive vomiting, and there is loss from the blood into the lumen. Okay, then this is another important consequence of intestinal obstruction. Okay, so the patient is in strangulation, and you release the obstruction or strangulation due surgical procedure or anything. Okay, then patient may suddenly deteriorate rather than improve. Okay, so what is the pathophysiological mechanism behind rapid deterioration of the patient after release of the obstruction? Okay, so you can see in strangulation means the blood supply to the bowel is compromised. Okay, so the bowel, the tissues and cell in the bowel, they are using the anaerobic metabolism process, and in that process toxic substances, free radicals, lactic acids, and all various these electrolytes, especially the potassium, they are leaked from the cells. Okay, and they are accumulated in the bowel wall, in the lumen and peritoneal cavity. When the obstruction is relieved, when the constriction bands are relieved, all these toxic materials are absorbed immediately in the blood circulation, and it leads to decompression of various systems, including the cardiac and respiratory. Okay, and there is excess of the bacterial endotoxins, okay, especially the gram negative toxins into the blood circulation, and the patient deteriorates. Okay, so remember, strangulation, release of the strangulation sometimes may be life threatening. Okay, so pathophysiology. What is the pathophysiology behind strangulation? You see, when there is obstruction, there is gradual increase in the pressure of the intestinal lumen because of accumulation of the fluid. Okay, there is venous compression and venous return is compromised. Okay, that leads to increase in the capillary pressure and loss of fluid, and even the RBCs into the